Hi, Dr. Kevin Windisch from Sparks Pediatric and Adolescent Medicine again. I don't know if you can see me. Welcome to our video series for students. Today we're talking about dehydration and fluid maintenance. If we can help you with the rotation, give us a call. We'd be happy to see you here at 775-359-7111. So, again, today I have students, anonymous student number 1, number 2, and number 3, which will be some disembodied voices off of camera while we have this discussion. So, student number 1, that's you. The first thing we have to do is decide how dehydrated a patient is, and we break that up into mild, moderate, and severe. And this is a clinical diagnosis, not a laboratory diagnosis. So, what are the findings?
Well, there's two different ways that you can do it. You can do it if you have a weight loss due to illness.
Okay.
You can take their pre-weight or pre-illness weight and subtract in kilograms and subtract from it their.
Which is one reason why I weigh every patient who comes in here every single time, even if they're here for a hangnail where I don't really need a weight, because I never know when they're going to come in vomiting. Mm-hmm. Problem is, invariably, you saw the kid 2 months ago, and he's a 6-month-old, and he's due for a 6-month follow-up or a 6-month well visit tomorrow, but he's here throwing up today, and he weighs a kilo over last visit, but you knew he grew over the last 2 months. So what do you do with that? Well, now we default to plan B.
Okay. So if you're going off of clinical observations for mild dehydration, you're looking at skin turgor and touch is going to be normal. The buccal mucosa of the lips will be moist. Their eyes should be normal. They should be able to still cry tears. Their fontanelle will be flat. If they're crying, they should be consolable. And everything else, peripherally, pulse quality, capillary refill, and urine output should still be normal.
Okay. With moderate dehydration?
Skin turgor, you might see some tenting now, and the skin will be dry.
Okay, or doughy.
Or doughy. The buccal mucosa of the lips will be dry. The eyes will start looking like they're deep set.
Okay, and actually the mucous membranes in mild may be moist, they can be tacky. Okay, so slightly decreased.
Okay.
Okay, so eyes sunken, decreased tears. Fontanelle should still be flat, it really shouldn't be sunken.
Okay. They're going to be more irritable. Their pulse, you may see an increase in the pulse at this point, and it may be weaker.
Okay.
Cap refill, we're starting to see stay right around 2 seconds here.
Okay, good. Okay. And then severe, they'll have tenting.
They'll be clammy. Parched or cracked lips. Sunken eyes. No tears.
If they have a fontanelle, it'll be sunken.
Right. And the pulse, they'll be lethargic or obtended, increased pulse rate, and their cap refill, you're starting to see it greater than 3 seconds now.
Okay, and their BP will start to drop. Okay, mild should have normal blood pressure if you're able to get it, moderate orthostatic changes, severe supine changes. Okay, i.e. shock. This then translates into 5%, 7 to 10%, 12 to 15%. Okay, or 50 milliliters per kilo, 100 milliliters per kilo, 150 milliliters per kilo. Okay, as far as your fluid deficits.
Okay.
This is replaced as normal saline. Okay, conspicuously absent from the clinical criteria is laboratories. All right, I've been called by ER saying, you need to admit this kid, he's dehydrated. I said, what physical findings does he have? He goes, I don't know, I haven't been in there yet, but I don't have labs. I said, is he dehydrated? He said, I don't know, I don't have labs back. I said, I don't care what the labs show. It's not a laboratory diagnosis. It's a clinical diagnosis. What's he look like? He said, I don't know. I haven't been in there yet. I said, then why are you calling me? You can get this kid out of my ER is why you're calling. I want the kid to see a doctor. Okay, so we're going to replace it like this. Now, laboratory does come into play, though, when it comes time to do your replacement. If your sodium is high versus if your sodium is low or normal. Okay, if your sodium is high, okay, or your sodium is low but your glucose is high, because your glucose will dilute out your sodium or artificially dilute it out. Okay, it'll give you a false dilution. You can come on in. I.e. DKA. You have in these cases a high osmolar load. And in the cases of high osmolar loads, you want to give your replacement over 36 to 48 hours. Give it slowly, otherwise you cause cerebral edema. If your sodium is normal or low, okay, then you can give half in 8 hours and half in 16 hours. So in 24 hours you can have your dehydration replaced. Wying into this, you need to put the patient on maintenance, assuming that they're NPO or they're not able to tolerate POs. We need maintenance. So in maintenance, you need to give the kid really 3 things. You need sodium, you need potassium, and you need water. So how much sodium does a patient need?
Normal is between, let me find it, it's let's say it's like 130, I'll find it.
Now it's going to be per kilo. It's 2 to 4 milliequivalents per kilo.
Sorry, I was thinking of lab values.
Okay? And your potassium is half that. How much water do they need? Anybody else know the answer?
Depends on their weight.
All right, so how do we do it?
0 to 10 kilograms. It's 100 mils per kilogram per day.
Okay? And then for kilos, so if you have a 20 kilo kid, you first work the 0 to 10 out, and then in addition to that,
So then
for
11 to
kilos
20
11 to 20,
is 50.
and for kilos 21 plus,
Is 20.
okay. Okay? Or we can do it per hour, and it's 4 to 1 milliliter per kilo per hour. Okay? We can work the math on the sodium, all right, and then just using your stock solutions, and this discussion is for non-neonates. If we're dealing with neonates, we use custom solutions, and we work the math on the sodium. But if we're dealing with non-neonates, we can get by with stock solutions because they're a lot easier and a lot cheaper, and not every hospital pharmacy has the ability to do stock solutions. And that being said, we can distill it down to this. If the kid is less than or equal to 10 kilos, use D5 and quarter normal saline. And if they're over 10 kilos, you can use D5 and half normal saline plus 20 milliequivalents of KCl per liter. And we're going to Y that in to the replacement fluid. Going back to the fluid replacement, if the kid is in shock, if the kid has decreased blood pressure, elevated pulse, we can bolus them with 20 milliliters per kilo of saline until we get them out of shock. Okay, once we get them out of shock, then and you just take that off the top of your replacement, then we give the rest as replacement. But we just Y this into the IV fluid. Okay. So they're going to get 2 bags running in through 1 IV. If the kid is vomiting, we need to replace their emesis. Normally you can get by with replacing it cc per cc with normal saline, because we don't want them to get further dehydrated as we're trying to catch them up. And you just replace that Q shift. If the kid is vomiting profusely, sometimes you need to add some acid and some potassium back to their replacement fluid, and we can use something called isolite G. G for gastric fluid. and you can replace it with that. Not every hospital has that available. What they add is ammonium chloride to get some acid in there. Not every hospital has ammonium chloride available. I will argue to you any patient who is needing isolite G because they're vomiting so much is hemodynamically unstable, needs to be in a PEDS ICU, and any hospital with a PEDS ICU should have access to ammonium chloride. And in this community, that definitely holds true. The hospital that does have a PICU has ammonium chloride and can do that. The hospital without a PICU cannot. But the kid who needs it probably needs to be in a PICU. If they're having tons of diarrhea, you need to replace that, and we can have the nurses measure that by weight. They just love doing that. And we replace that again, cc per cc. Normally you can get away with normal saline, but if the kid is having a ton of stool, a lot of times they'll become acidotic, because the stool tends to be alkaline. And if that happens, we can add some sodium acetate into the normal saline that we're replacing it with. So instead of normal saline, you can use half normal saline and half normal sodium acetate. And that'll fix that. You need to watch those kids' electrolytes closely. And again, if you're having to do that, that kid needs to be in an ICU. So distilled down like this, it's actually pretty simple. As you're looking at it in your textbooks, and just for the sake of everybody following this lecture, we're using Harriet Lane Handbook for House Officers. Which edition are we looking at?
This
Student
is
number 1?
19.
Edition number 19,
18.
or edition number 18. But this is the same discussion that's in edition number 16, or number 17 and number 16. It hasn't changed. Actually, this goes all the way back to when I was a resident. Really, the discussion in there has not changed. The graphics are a little better in the current edition. But going back to when I was a resident, which I think was like edition 12, there's really been no change in how we handle this. Now, what I see happen a lot is that people will admit the kid to the hospital and they'll say, well, he's dehydrated, so we're just going to put him on 1.5 times maintenance. And that'll catch him up. Okay? The problem is, if we look at how we replace the maintenance fluid with the normal saline doing the clinical discussion for a kid who's 10% dehydrated, if we have a kid who is under 10 kilos, where they need to be is here, and where that places them is pretty close. Okay? But as the kids get to 20, 30, 40 kilos, actually, can you give me another color? So where we want them, it underestimates what they need a little bit. Okay? But at less than 10 kilos, if you give them enough time, you will catch them up. However, the disparity as far as their needs, as the kids start to weigh more, goes up and up and up. Once you get much over 20 kilos, you're never going to catch these kids up with 1.5 times maintenance fluid. And if they're having ongoing losses, i.e. vomiting, you risk getting behind the 8 ball. And I have definitely had kids where I've cared for them on call where they've been admitted by colleagues and they were given 1.5 times maintenance fluid, no replacement, nothing PO. Nothing for vomiting. They were admitted, when you read their admitting note, assuming that what's in the admitting note was an accurate clinical picture, or an accurate description of the clinical picture, they were 5% dehydrated. I show up the next day, the kid's vomited 4 times in the hospital, now he's 10% dehydrated. We put the kid in the hospital and we made him worse. That's unacceptable. And this is a textbook that every pediatrician carries in their bag. So now you guys know what the content of that chapter says, and you know how to use it. You may not have it memorized, that's okay. That's why we carry it in our bag. This is Dr. Windisch. I hope this has been educational for you. Again, if you'd like to schedule a rotation, give us a call here at 359-7111. We'll see you next time.